Now, having said that, I will tell you that you'll need to know classes of drugs as a generality. So if I say something like a vasodilator, you don't have to know the specific vasodilator per se, but you should know what a vasodilator does. Just some other terms. Inotropic, I think we've seen before as far as the force of contraction, dealing with contractility. Chronotropic, having to do with the speed of the heart rate. So for instance, dopamine is both inotropic and chronotropic, where dobutamine is just inotropic. Right there. I just told you. You might have to actually take notes. What a foreign concept. All right. So PVO2, arguably the single best number to look at to evaluate that balance between supply and demand. If demand exceeds supply, you're going to have a reduction in PVO2 coming back. If the opposite is true, it goes in the opposite direction. We know that that's the gradient which causes from capillary to cell. In theory, the uncapillary PO2 reflects that balance between delivery and uptake. Normal values 35 to 45. Okay. Now I think I have this blown up for you in the back. This was actually something that a couple of physicians and I put together to help train the residents on how to deal with hemodynamics. So the first thing we look at is we look at the PVO2, and if we happen to have an SVO2, do the two correlate. So normal PVO2 is 35 to 45. Normal mixed venous saturation is about 75%. They should go hand in hand with each other. As the PVO2 drops, the saturation should drop, and vice versa. So there's three situations you could have. Take the middle one first, and that's looking at a normal PVO2. It's telling me that basically the flow is adequate. The supply is being matched for the demand that's being placed on the patient. And what you need to do in that case is take a look at specific organ perfusion. Things like, are the kidneys getting enough blood flow to maintain a normal output, urine output? Is the patient's sensorium appropriate so that they're not confused, comatose, whatever? You want to see a good situation there. If this PVO2 is elevated, that means that I have flow in excess of demands. So either demand has gone down, okay, or supply is in an excessive state, what we're going to call a true hyperdynamic state. Also, this could be a situation where if you draw the blood too quickly off of a distal line, the distal port, so if you're drawing it off the yellow on a PA catheter, the yellow port is the distal. If I draw that too quickly, I'll end up having arterialized that blood, and you get an elevated value. So it's a very slow draw if you ever have the opportunity to. If the PVO2 is low, it means I have inadequate oxygen transport. In this case, supply is not matching demand. Demand is outstripping supply. And really in all three cases, we come back to looking at that oxygen delivery, oxygen consumption, and how the two of them are related to each other. First of all, we go to the oxygen demand component of it. If I have an elevated oxygen demand, is it because of these reasons? Those are things that might cause the demand to be increased such that the supply cannot match it. And you end up with a low PVO2. So far, so good? Then you want to look at the oxygen delivery as it's compared to the what makes it up. Well, we know that oxygen delivery is cardiac index. We also know that it happens to be oxygen content. So we look at, for the cardiac index component of it, our old friends preload, afterload, and contractility. Preload can be assessed by the wedge pressure. Afterload can be assessed by the vascular resistance in the systemic circuitry. And we have not talked about this, but there is a number that we can use to evaluate contractility. It's called the left ventricular stroke work index, as far as what's available on the left-hand side. There's also right ventricular stroke work index, but that's on the right side of the heart. And then oxygen carrying capacity, you want to look at things like the amount of hemoglobin you have, the amount of oxygen, the PO2 saturation, those other non-carrying forms of hemoglobin like carboxy and methemoglobin, and then evaluating oxygenation by looking at all of our oxygenation indices that we just love, right? So far, so good. We're using the PVO2 as a starting point to say, are we matching demand and supply? Because if we're not, we're going to call that shock. That's the definition of shock, is that there's not a relationship which is optimal and the PVO2 is normalized. There are 5 types of shock that you'll need to be aware of, because we're going to, on the exam, I will give you some hemodynamic data, and you'll tell me what kind of shock it is. How fun is that? Not very. So, 5 types. Hypovolemic, as the name implies, we're talking about a reduction in vascular volume. Cardiogenic, something where the heart muscle itself is impaired, and we'll find when we talk about EKGs that an anterior wall MI is quite often associated with a reduction in pumping function. Septic shock, where the vasculature loses its ability to maintain arteriolar tone, so you end up having massive vasodilation. And in the process, you end up with this hyperdynamic state where you end up with cardiac outputs of 10, 12 liters per minute. There's nothing to stop it. It just runs rampant. Okay, not a good thing, by the way. Neurogenic shock, which is basically where you lose a sympathetic tone. You have a high fracture of your spinal column, and you basically lose the ability to control blood pressure. And then finally, obstructive shock, where there's some sort of a blockade to pumping function. Most common when you might encounter something like cardiac tamponade, where the pericardial sac becomes filled with fluid and you lose the ability for the ventricle to contract and the atria to fill. Another example might be the case, at least on the pulmonary circulation, a saddle embolism, where you end up having this big blockade of the pulmonary artery. And in essence, you're not getting blood flow back to the left side either, and you go into massive shock. Tension pneumo, where you end up having the mediastinal shift to the extent that you have the superior vena cava, inferior vena cava, and the aorta all contorted. So again, hypovolemic shock is loss of volume, hemorrhagic shock. This is what we end up finding if we look at that process. You have a reduction in preload. So CVP, wedge pressure are reduced. Because preload is reduced, I end up having a reduction in cardiac output, cardiac index, blood pressure, mean arterial pressure. What the body attempts to do is to use the other 2 things to correct for it. Preload is down. I'm going to increase the heart rate to compensate. I'm going to increase the vascular resistance to compensate. In other words, it shunts the bloods away from the non-vital areas. Patients appear cold, clammy, diaphoretic. Why? Because I'm not shunting blood to the periphery. Who cares what the great toe is as far as its perfusion? I want to get blood to the brain and to the heart. You'll see a reduction in bowel function. You'll see a reduction in renal output, all because they're trying to conserve the volume they have. Okay. In the process then, because I have a reduction in cardiac output, I have bigger extraction happening. trucks going through the neighborhood slower, more fruit is pulled off. So I have an increase in the AVO2 difference, and if you actually look at oxygen extraction ratio, it also goes up. So long as the flow is being maintained, oxygen utilization, oxygen consumption remains normal. Once that delivery is no longer being matched by the demand, then you'll end up seeing the PVO2 fall. So initially, it's maintained, but over time, you'll end up seeing the PVO2 get reduced because more is extracted. Coulon hypovolemic.
So you increase the heart rate?
The body's compensatory mechanism is to increase the heart rate, increase the contractility, and increase the SVR.
But oxygen utilization remains normal?
As long as it can do that. At some point along the line, though, you're not going to have the vascular volume to keep up. And that's when you start seeing the PVO2 fall. I will tell you that the examples I give you are ones where you're seeing that fall. Okay. Treatment, replace it. Whether it be blood, crystalloids, colloids, whatever. Just get some, fill the tank back up. Type 2, cardiogenic shock. Something with the pumping of the heart. The actual contraction is impaired in some fashion. There is a classification, I don't expect you to know it, but it's called the Killip classification. And if you'll notice, it all has to do with the degree to which you're seeing congestive heart failure developing. Class 1, there's no evidence, no alterations in breath sounds. As you go from 1 to 2 to 3, you're seeing it go, in an upright patient, go up the lung. So more and more crackles are apparent. It's not just in the bases, now it's halfway up. Now it's not halfway up, now it's 2/3 of the way up. Okay, and it's basically showing that you're having more and more areas that are involved with blood backing up into the interstitial space and across into the alveoli. Frank pulmonary edema. Class 4 is classified as cardiogenic shock, where you start seeing that impairment be so severe that you don't have the cardiac output that is there. This is almost always associated with myocardial infarction, although there are situations where you have cardiac myopathies that can fall into this classification. There's multiple chemoactive agents that we give patients for different types of cancer, and the side effect is that they end up having development of cardiomyopathies and an inability to pump. Kind of you kill the cancer, but it kills you. Kind of a sad situation. As we'll find with myocardial infarction, depending upon the site, whether it's anterior, lateral, septal, inferior, posterior, you'll end up having ECG changes over those areas of the heart. And you'll notice this by looking at alterations in serum enzymes, and we'll talk more about them when we talk about an MI. And you might also have situations where you either have tachydysrhythmias, so rapid heart rates, or you may have situations where you have bradydysrhythmias, blocks in the presence. So both directions are possible when you have this acute coronary problem. We go on cardio. Oh, we're not done yet. Again, here the problem is contractility. I lose muscle mass, I lose contractility. So the value that would fall would be the stroke work index, which we haven't really talked much about, but that's one that you can look towards. What the body does to compensate, if contractility don't work, it's going to try to compensate with the other ones. One, again, it tries to clamp down and increase systemic vascular resistance, again giving us that cold, clammy picture. It also increases the heart rate as an attempt to compensate. And again, same kind of a picture. So long as it's able to maintain, PVO2 looks normal, but in the case we're going to have, it's going to be reduced. So what you'll end up seeing in these patients is basically an attempt to optimize preload by giving this person fluids and maintaining a wedge pressure that's significantly higher than normal. So you're going to see wedge pressures higher than a normal of 12, probably in the order of 18 to 20. And it's one of those fine lines. You need enough to stretch the fiber to optimize preload without going into failure. So too much in pulmonary edema, too little, and you got no cardiac output. Okay. We also look at treating a myocardial infarction with things like thrombolytic therapy, Retaplace, recombinant TPA, percutaneous transcoronary angioplasty is what that stands for, which basically means that I go and we redilate the obstructed coronary artery, put in a stent, and hopefully that allows for perfusion to end up happening. We'll also do things like inotropic support, so trying to maximize what contractility is left, getting the most out of it. So we'll use things like dopamine, dobutamine to try to improve it. And we'll also you wouldn't think, if I got a patient who's hypotensive, why would I give a vasodilator? Well, it's to reduce the work. So at the same time I'm improving the force of contraction with dopamine, I'm also using nipride to vasodilate. It seems counterintuitive, but it actually sometimes this SVR that is increased is not a good thing. It's actually putting more work on the heart. And then lastly, the IABP stands for intra-aortic balloon pump counterpulsation. So basically you're going ahead and during diastole, you're inflating a balloon in the descending aorta that improves diastolic pressure with the hope that you're able to increase coronary perfusion pressure and get fresh blood to the myocardium. I don't know if you've ever seen, has anybody ever seen a balloon pump? Yeah. It inflates during diastole and deflates, obviously during systole. It'd be kind of hard to pump against a balloon that's obstructing your aorta. And it does it in milliseconds. There are hospitals where the individual responsible for a balloon pump is the respiratory therapist. So it is a skill set that we will talk more about as we go along. Now, let's talk about it now. I didn't know I had a slide in there, but okay. Again, this is where we see something where we have reduction of perfusion, leading to left ventricular dysfunction. We'll also see with different valves quite often that they can't maintain diastolic pressure because they either have a stenotic mitral valve or have a valve that's inadequate and is causing some regurgitation. This is what it looks like. Okay, and it basically is hooked up to a machine that then goes ahead and it's descending aorta after the left subclavian artery, obviously. And it goes ahead and inflates during diastole and deflates during systole. Here's a picture of it being placed. It usually goes in through a femoral artery. It's threaded up. It's got to be above the renal, but below the left subclavian. So you got a little bit of a distance there. You don't want to obstruct either of those two. And you can see it's inflated here. You can see the whitish portion, and then deflated. It's all shriveled up. So during diastole it inflates, during systole it deflates. Cool? Goal to increase diastolic pressure, increase coronary perfusion pressure. Remember, the heart only feeds itself during diastole. And it's basically timing itself to an ECG tracing so it knows when systole and diastole happen. And you can see that I end up having during diastole normally a reduction when there is not a pump there, but inflating it during diastole, now I have an increase in diastolic pressure. And we talked about it, displacing blood into the coronary arteries. And then actually the deflation during systole is a little bit of a vacuum and helps left ventricular afterload go down. and it's a much more efficient process, and hopefully increasing cardiac output without having an increase in myocardial oxygen demand. For right now, don't worry about this. We'll come back and visit this when we talk about EKGs. But that in anterior and lateral infarcts, which are due to the left anterior descending and left circumflex artery becoming obstructed, you'll often have tachycardia. In the case of the inferior wall, you end up, and to some extent the septal wall, you'll end up having bradycardia because that impairs the conduction section of the heart. Remember, it's not the heart muscle is, or the heart tissue is made up of not only myocardial fibers that are there for contraction, but there is also a conduction process where it goes from the SA node through the AB node and on down. A inferior right coronary artery, septal artery, or septal infarct, they'll all have the potential of affecting that conduction process, and you end up with blocks and severe bradycardias. And as we'll find, the leads that showing ST changes are indicative of what part of the heart is involved. So 2, 3, and AVF all point down, so it must be an inferior wall MI. Septal V1, V2, V3, V4 anterior, and lateral being everything that looks left. More on that later. You don't need to worry about that just yet. Okay?
So it won't be on this first one.
I'm not on the first one.
Okay.
Guaranteed it's on the second one.
Okay.
In depth. Because you'll be given a 12 lead and you're going to tell me where the MI is. Third type. Okay? So hypovolemic, cardiogenic, septic. Septic, as the name implies, is due to septicemia, usually bacterial, but it can be really, anything. Gram-negative are more common to be as being a source of the infection. What ends up happening is that organism releases endotoxins, and those basically do a real whack job on the vasculature. Not only does it make the vascular tone vasodilate, you lose the arteriolar ability to constrict. You also have a leaky capillary now, where all of a sudden the vasculature, that fifth factor in Starling's law, the capillary permeability becomes a sieve, and you have fluid third spacing out of the vasculature into the interstitial space. You also screw up nastily the normal clotting mechanism that is there, and you end up with coagulopathies, things like disseminated intravascular coagulation, DIC. If you've ever encountered that, they bleed where they're not supposed to bleed, and they clot where they're not supposed to clot. And it's just what do they call a hot mess? I think is the medical term for that. So what we end up finding is, again, somebody with a reduction in blood pressure, mean arterial pressure, and most significantly, you see systemic vascular resistance plummeting. Because you lose vascular tone, you vasodilate like the cow's coming home. Okay? Which partially is why you have that flush appearing during septic shock. You just have nothing stopping the cardiac output. It's just running rampant. Wedge pressure, CVP pressure, initially at least, is normalized, so you don't see a reduction or an elevation in it. And what the body attempts to do is try to increase cardiac output again by trying to increase myocardial contractility, by trying to optimize preload, because it knows that the afterload has been destroyed. Fixing it, you got to find out what's causing it and give appropriate antibiotic therapy. We can support with fluids, trying to make sure that wedge pressure doesn't deteriorate. Vasoconstrictors might help, might not help. And there is this whole process of going from what they call hot sepsis to cold sepsis. Hot sepsis is the initial insult, and where the patient actually is maintaining a normalized body temperature, is actually an elevated body temperature. And then cold sepsis is the end stage where your body just shuts down. And usually by that point in time, we're talking multi-organ failure. We're talking renal failure. We're talking ARDS. We're talking splanchnic or gut problems, where you end up having bowel infarctions. And there's a whole, this is actually a great tutorial on septic shock. I don't go as deep into it as I probably should, but you're probably saying, Rick, you've gone deep enough, thank you very, very much. But if you're interested, Critical Care Medicine Tutorials, CCM Tutorials, is a great site, and they have a great thing on sepsis and sepsis management. Fourth type, neurogenic. Neurogenic meaning there's something with the connection between the brain and the peripheral nervous system. Often you might even see this simply as a vasovagal response, but often it's the spinal cord trauma that you end up seeing involved. Again, loss of blood pressure, loss of mean arterial pressure. The body's normal control of heart rate is impaired also in this sense. You end up with a significant bradycardia. Usually vasoregulation is not so much a problem, but you may see the vascular resistance depleting as you go along, and normal response is to try to get cardiac output up in any way fashion that you can. Treatment is just basically trying to get volume replacement and using vasopressors to improve vasomotor tone. In a lot of cases, these are end stage. These are what basically cause the demise of the individual, and often they're in neurogenic shock in the field. So by the time they get to us, they're basically, in a lot of cases, not salvageable. Lastly, obstructive, and I told you some of the mechanisms there, and the treatment is very obvious. Remove the obstruction. If they got a cardiac tamponade, do a pericardial centesis and drain the pericardial sac. If they have tension pneumothorax, do a needle decompression chest tube. If you have a massive PE, you'll find out on autopsy that was a massive PE. So not a whole lot you can end up. Having said that, I actually have a friend, she's a nurse, she was at work, worked the ER, ended up throwing a saddle embolism. They gave her TPA, busted the clot, and she turned out fine. But had she not been in the ER when the symptoms started and somebody was bright enough to recognize it, she'd be dead. Okay, so here's what you may see on a test. Okay, some various parameters, and I will give you these values so you don't have to calculate them. Okay, so what do you notice as being out of range here? First of all, start with the PVO2. Little low. It's low. Okay, because the body will do everything it possibly can to maintain a normal PVO2. If you're seeing a low PVO2, something's out of whack. So I have demand exceeding supply. Why? What type of shock do we have here? Don't all answer at once. It's okay. Is it hypovolemic shock? Yes or no? It's a 50-50 shot, guys. No. Why? What's the hallmark of a hypovolemic shock? Decreased volume exhibited by preload, right? Is this preload reduced? Is this preload normal? How do I measure preload? Hello? CVP, pulmonary capillary wedge pressure. Vaguely remember these from 1050? Okay. Are they normal? They're increased. That's not good. What's going to happen when your wedge pressure exceeds 20? What do you start seeing happening? Pulmonary edema starts leaking into the vascular space. What kind of shock would be present if you had an elevated wedge pressure like that? Cardiogenic. And this is a situation where cardiac output doesn't look that bad, but look at cardiac index. So this person's body size, that 3.7, although that's not too far off normal, 1.67 is dramatically, 2.5 to 3.5 is normal value there. And if we look further, left ventricular stroke work index, that value is reduced also, so contractility is down. Okay. And again, I'll give you all the normals, so you don't have to worry about that. Okay? Cardiogenic shock. How do I treat it? Inotropes, optimize fluids, perhaps vasodilate, perhaps vasoconstrict. Well, it seems counterintuitive, but you kind of go both. There's multiple ways to attack that piece. How about this one? PVO2 is it's low. Little doesn't count. Okay. It's not something where, oh, you know, it's close. No. If it's low, it's low. If it's high, it's high. Okay. Why? Who's the causative factor here? PVO2 is low, isn't it?
Yeah.
Okay. Is it because supply is impaired? Is it because demand is elevated? Demand's up. Supply is not a problem. My cardiac index is 4.5. Cardiac output is 7.5. Okay. Which of my shock states has a hyperdynamic response? Okay, what else would you look at to see if it was septic shock? What's his temp? Elevated. Okay, so it's what else is the hallmark of septic shock? What happens to the vasculature? Dilates. So what happens to the vascular resistance? It plummets. And 836 is a dramatically low value for a vascular resistance index. Okay. Put the pieces together. If you understand what the causes of the shock are for each of the 5 states, you get a very clear picture of what's happening. And yeah, there's a lot of data there, but you got to know which pieces to pull out. What's real life? You got a ton of crap, and you got to know where the golden nuggets are, sifting through it. Fair? One or two. And I think we'll stop there.